Good morning, everyone. I'm Dr. Vinutha Shree, and I'm going to present about a case report of a small blue cell carcinoma, adamantinoma like Ewing sarcoma causing proptosis.
Slides can move करें.
Slides. So coming to our OPD was a 42-year-old female patient presenting with redness and swelling in the right eye lower eyelid since 2 months. She complained of diminution of vision and also history of restriction of movements were present with no history of any ocular trauma or previous surgeries. Patient had consulted a private clinic where oral steroids were given and abruptly stopped after 3 days. Coming to the anterior segment examination, we could find that there was abaxial proptosis in the right eye with swelling in the lower eyelid, but other parameters appeared normal. On inspection, we found that there was a right eye axial proptosis, but the other parameters on the inspection, for example, Valsalva maneuver and all, were all normal. Coming to the palpation, the inspective findings were confirmed. Finger insinuation test was positive as we could insinuate the fingers between the globe and the orbital rim, but on retropulsion test we felt resistance on pushing the globe backwards. There was no thrill, supraorbital, infraorbital anesthesia and no Bruyne auscultation. On the proptosis evaluation we could find that all the parameters of the axial proptosis, axial, horizontal and vertical dimensions of the right eye were 5 mm more than the left eye, indicating that there was an abaxial proptosis of the right eye. Coming to the MRI, we found that there was a mass in the retroorbital region pushing the globe of the right eye downward and outward. We further took the patient for an anterior orbitotomy where right eye vertical lid split was done and debulking of the mass was done, and the mass that can be seen here was sent for histopathological examination. On histopathological examination, they had given a preliminary report of a small round blue cell carcinoma, query retinoblastoma or neuroblastoma. As we can see in this image, there were multiple small round blue cells. And on this image, we can find that there were pseudo rosettes present. On further sending the patient for IHC reporting, we found that the patient, it was positive for CK, EMA, synaptophysin, chromogranin, NSC, CD99, P63 and negative for LCA, S100, Desmin and GFAP, which gave an impression of the adamantinoma like Ewing sarcoma. So ALES is a rare malignant tumor which is characterized by EWS R1 is to LF11 related fusions and complex epithelial differentiation. ALES poses a tremendous diagnostic challenge owing to resemblance to a wide variety of common head and neck malignancies. It's a rare aggressive malignancy that mimics diverse neoplasms in the head and neck region. Awareness of the morphology and immunohistochemistry spectrum of this tumor is really important to avoid the diagnostic errors. Diagnosis of this type of tumor is based on its histochemical and immunohistochemical characteristics. For an Ewing sarcoma, it contains glycogen, so it will appear as PAS positive and also immunoreactive for NSC, Vimentin and S100 protein. A recent study also demonstrates that it is highly immunoreactive for CD99, which is indicative of high expression of MIC2 gene product. So the take-home message for my presentation would be that IHC marking is very important, and also molecular genetics is really important for diagnosing correct diagnosis of the malignancy. Because in the earlier report it came as retinoblastoma or neuroblastoma, but on IHC reporting we could finalize that it was an adamantinoma like Ewing sarcoma. So so we can have facilitate a more accurate subclassification and tailored therapeutic approach. Thank you.
In your case, how long back the patient had that proptosis?
She had, she presented to her OPD with swelling in the right eye since 2 months.
2 months.
Yeah.
Or was there any other time lag? I want to ask, there is no metastasis in your case. You operated and it was...
We have sent for a PET scan because she came at 2 months back. She had it from 2 months, but she reported to her OPD like around 2 weeks back.
So PET scan is free?
It has been done now recently, and we could find that there was a metastasis in the liver. So it is now presenting as a metastasis of Ewing sarcoma. metastatic like Ewing sarcoma. So previously we had diagnosed her for retino and neuroblastoma. We were suspecting that, but she wasn't responding to the chemo or the radiotherapy. So we further sent her for IHC reporting, where it came as adamantinoma like Ewing's. So on further diagnosis on a PET CT, we found that there was a metastasis in the liver. So now aggressive treatment has to be started for her, and she is complying for the same.
What does the literature suggest to you? How much is the metastatic rate and what is the prognosis for these type of patients?
According to the literature, the metastatic rates, first of all, Ewing's is a very rare malignancy in adult to present in an adult patient. But so metastasis will be more common in, like if it is already a rare presentation in an adult, there will be chances of metastasis as well. So around 1%, according to the literature in the article which I read, 1% of patients will have metastasis, and prognosis is very poor in such cases.
So your patient was very unique, having that was like 1% of the literature.
Yes,
that means we should follow this patient further.
Yes, sir, we are
So, like the pathologist whosoever use the marker, so is it possible? I mean, who decides ki, suppose this is not usual tumors which you suspected? For my own practice, I am asking you. So, can it be done in the first go itself, so as to save time? If there is any metastasis, we can prevent it. I mean, take up the case earlier. So who?
So that is the aim of my case today, ma'am. That to
Okay,
start.
if it's not responding, then you go back, ask them to use more marker, then you come to a diagnosis, and by that time metastasis is already there.
No, ma'am. Like to start, like not to rely on the HP report and to send for IHC marking immediately.
Generally, if the pathologist is not very clear of the pathology, and they already write it as a last line, that most of the times they subject the specimens for IHC, they at least recommend. So immediately once you have the basic histopathology in your hand, you can get a IHC done, should be done, so that you know the details of the tumor as well as the stage and markings.
Again, she said it's a very rare tumor. So do we, while we ask them for IC markers, do we go for all rarest tumors or the commonest one? Because most of the time
There are two ways of doing IHC. That also depends upon which center you are sending. One is they will direct their markers to the target which you are asking them to do. And second is they will keep on doing till they get the proper diagnosis. So it's always nice to have the second part done so that they reach on to a conclusion. Not very expensive. There is generally a 2,000-3,000 difference, but then otherwise it is there.
Thank you.